Good morning, good afternoon, or good evening, whatever you are. My name is Abdel Rahman Nimeri. I'm the IFSO Secretary Treasurer, and it is my pleasure and great privilege to welcome you all from here in my house in Charlotte to the IFSO webinar journal club talking about the IFSO position statement on SADI. We've assembled a tremendous faculty for you from all across the world. And today we're going to have Professor Miguel Herrera from Mexico do the presentation, and then we'll have a panel that I will present to you shortly, have a great discussion about this procedure. Just few items to just make sure that you're aware of. This presentation will be present at our IFSO YouTube channel and the IFSO Virtual Academy from tomorrow. Please send us all your questions in the chat function. We'll try to address them in the 50 minutes after the presentation. So to just present our faculty, Professor Miguel Herrera from Mexico is a professor of endocrine and bariatric surgery at the National Autonomous University in Mexico and the National Institute of Medicine. Is the president of the Mexican Society of Metabolic and Bariatric Surgery, and he is our chair of the IFSO scientific committee, and he was very instrumental in putting this position statement together. We have also Professor Ala Abbas from the Middle East North Africa chapter from Egypt. He is a professor at the Department of General Surgery at Ain Shams University, Cairo in Egypt, and the current president of the Egyptian Society of Bariatric Surgery. We have from Australia at 11 p.m. at night. Thank you for doing that, Professor Wendy Brown. She's the program director at the Surgical Services at the Alfred in Melbourne and the head of the Monash University Department of Surgery and the director of the Esophagogastric Bariatric Unit and the clinical director of the registry in Australia and New Zealand. And she's also the chair of our IFSO registry committee. We have from Canada, Dr. Laurent Berthoud, minus 18 degrees this morning, professor at Laval University in Quebec, director of the research and chair of bariatric and metabolic surgery, and he's a member at large for the IFSO North American chapter. We have from Chicago, Professor Vivek Prachand, professor of surgery and chief quality officer at the Department of Surgery, University of Chicago, Medicine and Biological Sciences. Last but not least, we have our own past president of the IFSO Board of Trustees, past president of IFSO, Professor Antonio Torres from Madrid, Spain, head of the Department of Surgery at the Hospital Clinic San Carlos in Madrid, and member of the IFSO Board of Trustees and previous past president. So before we start the presentation of Professor Herrera, we are going to have 5 polls during this event, and we would like to know your opinion. So the first poll is going to be launched now, and as you all know, Manuela is in the background making sure that we do these things right. So thank you, Manuela, for launching the poll. So the first poll is my biggest reservation about recommending DS or loop DS to patients, both of them. So select one of the following. And I want to ask first someone who was very instrumental in putting this position statement, the past chair of the IFSO Scientific Committee, Professor Wendy Brown. I'm going to ask each one of you, what percent does SADI DS represent in your practice, and give me your opinion about this question. So Wendy, if you can please try to answer this poll for us.
Thank you very much. I'm not sure if I should have my webcam on or off at the moment. Should I have it off or on?
Yes.
Sorry.
On is fine.
On? Okay.
Yep.
Look, I haven't done a SADI DS as yet. It's a procedure I am watching. I guess I've been a little concerned because I inherited a practice where a large number of Scopinari procedures have been done, and I am intrinsically just very concerned about nutritional deficiencies. So I'm worried about the replacing of the diseases of obesity with the diseases of nutritional deficiencies and the diseases of the operation. So I have been very cautious in including this in my practice, and I guess that's why I was really excited to be part of the team that got to examine the literature, because I think it's important to know, for our patients' sake, where we sit with the literature before we offer them a procedure.
Great. So you can see the results of the poll, and spot on. People are feeling exactly what Wendy just articulated, the development of nutritional deficiencies. So I think this is a great prelude to our presentation. So if we can start by having the presentation of Professor Herrera, and then after that, we're going to have 50 minutes of discussion. So looking forward to the discussion.
Ladies and gentlemen, good morning, good afternoon, or good night, depending where you are. This is the position paper that I will be presenting today for discussion. First of all, I would like to acknowledge the authors and the members of the task force for their valuable work. Biliopancreatic diversions, either standard or with duodenal switch, have demonstrated to provide significantly greater weight loss than other bariatric procedures, with concurrent sustained improvement in metabolic conditions. However, side effects related with malabsorption on one hand and the technical complexity on the other have limited the broad acceptability of these procedures. The SADI-S, or one anastomosis duodenal switch, was proposed in 2007 by Sanchez Pernaute and colleagues as a modification of the standard procedure. The configuration is shown in the slide. The theoretical benefits of this procedure over the duodenal switch include reduction of the operative risk by eliminating one anastomosis while potentially achieving similar weight loss and the health benefits. For the purpose of this presentation, I will be referring to the procedure as SADI. Other similar one anastomosis duodenal switch procedures have been reported in the literature, with different names as shown in the slide. The previous IFSO position paper published in 2018 found that there was no medical evidence that demonstrated superiority of either the standard duodenal switch or the SADI procedure, noting that many nutritional problems take years to present and that there was no sufficient long-term data on SADI to comment on this issue. The ASMBS, in their 2016 position paper, determined that the SADI should be considered an investigational procedure, as they felt that there was not enough high-quality data to draw any definitive conclusions regarding the safety, efficacy, and durability of the procedure. In their updated statement of 2020, the ASMBS endorsed the SADI procedure as an appropriate metabolic procedure, highlighting the importance of caution, considering the lack of evidence regarding intestinal adaptation, nutritional issues, optimal limb lengths, and long-term weight loss and weight regain. To ensure that guidance is based on the best quality of the literature, IFSO has developed a framework to inform position statements. According to this framework, for this paper, the literature was reviewed and the following aspects were considered: safety, efficacy, long-term consequences, and 2-year expiration, at which time the current level of evidence will be re-evaluated and the position statement will be reaffirmed, updated, or modified. This review searched Medline from 1946 to March 2020, and BASE from 1974 to March 2020, PubMed until March 2020, and the Cochrane Library until March 2020. All study designs, study sizes, and follow-up time frames were accepted. Abstracts were included but separated from full manuscript publications. Information extracted from eligible studies included basic study data, demographic data, surgical technique, follow-up, weight loss, evolution of comorbidities, and complications. Here is the PRISMA chart. A total of 5,980 studies were identified. After duplicates were removed, titles and abstracts for 5,161 records were screened. 161 articles were assessed for eligibility, and 50 full-length publications were finally selected. These include 42 case series and 8 case reports, which were summarized in Table 1. This is an increase of 25 case series and 3 case reports since the last position statement was published in 2018. All studies were assessed for the risk of bias based on the Newcastle-Ottawa scale. Each study was assessed independently by 2 investigators regarding study selection, comparability, and outcomes. SADI has been reported in both primary and the secondary settings. 34 case series included primary patients with a total of 4,540 patients. However, this is an overestimation due to shared patients between some series. Most series reported weight loss at 12 or 24 months, with variable means of reporting this weight loss. Mean total body weight loss ranged from 23.6 to 39% at 12 months, from 39.6 to 42.9% at 18 months, and from 22.8 to 47.8% at 2 years. The range of the mean excess weight loss was from 62.4% to 102% at 12 months. There were 3 reports with follow-up at 5 years. The total body weight loss achieved at 5 years was 38%, with a 78 follow-up in one of these studies, 34.7% with 100% follow-up in the second study, and 22% with 78% follow-up rate in the third. Changes in type 2 diabetes diagnosis and treatment were reported in 28 case series that included primary patients. There was a significant improvement in both hemoglobin A1C and requirements for hypoglycemic agents. The detailed results were shown in a table. Early complications included anastomotic leaks, bleeding, and nausea. Long-term complications included gastroesophageal reflux disease, bile reflux, flatulence, dumping syndrome, and nutritional issues. The nutritional issues reported included malnutrition, hypoalbuminemia, vitamin D deficiency, hypocalcemia, hyperparathyroidism, and iron deficiency. Revisional procedures for these issues were variably described. There were 13 case series that included revisional surgery, with a total of 347 patients. Again, this is an overestimation due to shared patients. The weight loss achieved appears to be similar to the primary patients. Only one report had revisional patients followed 5 years. The majority of the remaining studies were limited to 2-year follow-up. The effect of type 2 diabetes, or the effect of the procedure on type 2 diabetes, appeared similar to the primary procedures. Early complications were uncommon in all series, with anastomotic leaks, bleeding, and nausea being the most predominant issues. Late complications were mainly nutritional, with several reports of hypoalbuminemia and iron deficiency. GERD, doping syndrome, and flatulence were also reported. The need for reoperation was not reported, although revisional procedures have been described. With this analysis, the conclusions and recommendations by the IFSO task force are: SADI offers substantial weight loss that is maintained into the medium term. The procedure provides improvement in metabolic health that is maintained also into the medium term. Nutritional deficiencies are emerging as long-term safety concerns, and patients undergoing these procedures need to be aware of this and counseled to stay in long-term multidisciplinary care. Bariatric surgeons are encouraged to participate in national or international registers in order to facilitate the learning of the outcomes. IFSO supports the SADI as a recognized bariatric and metabolic procedure, but highly encourages randomized controlled trials. Thank you very much.
Thank you, Professor Herrera, for an excellent presentation of the IFSO position statement. Let me start first by asking Professor Antonio Torres. So both Wendy and our audience feel like the major reservation they have is nutritional deficiencies, and Professor Herrera just showed us that we don't have really robust 5-year data, only 3 studies. How can you reassure people that it's okay?
I'd like to tranquilize, Wendy concerns and other people's concerns. Our experience with the SADIs 13 years after starting our study are very consistent. And you guys have to trust us. Regarding the sense of the secret is to follow up the patient. Miguel pointed out that the most important studies dealing with SADIs have more than 75% of follow-up. So it's essential to get nice result, the follow-up with endocrinologist, nutritionist, and the patient. And the patient have to be committed to do the follow-up and to follow the supplementation. This is the key. We don't have, or didn't have, any problem regarding controlling this nutritional deficiency. Of course, if it happens, we can to treat that. But here we have Vivek and Lauren and a lot of us, other experts with the standard duodenal switch that have more experience than us, and I think the same feeling than us.
Thank you so much, Antonio. So maybe let me ask Vivek the same question from both the perspective of SADI and DS. how do you deal with these patients' nutritional deficiencies? And do you have a certain algorithm for patients who you think are from a lower socioeconomic status, where you think, poverty and being able to afford these nutritional supplements will be an issue?
Yeah, so I think that's really gets to the heart of the matter, and I think is the rate limiting step with regards to adoption of DS or loop DS. I think that in terms of treatment, I think the best treatment is always prevention. And I think that you alluded to some of the strategies with regards to prevention in terms of identifying the patients who we think might be at risk. And I think that that's sort of an Achilles heel to all of obesity surgery, is being very accurate in making those assessments. With regards to just the development of nutritional deficiencies, I share Antonio's opinion about the fact that this is not something that we should be frightened of. But at the same time, I think that we need to have a healthy respect and understand. And I truly do think that the nutritional aspects of SADI, loop DS are going to be more complex than standard gastric bypass or one anastomosis gastric bypass. And I am concerned that as people adopt the technique, they're thinking of it more as a gastric bypass instead of more similar to duodenal switch. I do think that the ability to pay for nutritional supplements and so forth is a very important part of the patient screening process. And obviously different healthcare systems have different approaches with regards to purchasing of those medications, and that needs to be taken into account. For our patients, we tell them that they need to budget at least $30 a month to pay for their supplementation. But to put it in context, the thing that's different between DS versus gastric bypass is that we just have our patients take additional vitamin A and vitamin D that is water miscible, and that's very important, because with the fat malabsorption with these operations, the vitamins have to be in a form that's bioavailable and readily absorbed.
Great. Let me have Manuela launch the second poll for our audience. We want to get them involved. So I want to ask Professor Ala Abbas from Egypt to try to answer this poll for us. The most difficult technical aspect of DS or loop DS is what?
Thank you for having me today. I think the two operations have the same difficult step of duodenal dissection and transection. For bariatric surgeons who are used to handle the upper part of the stomach, it's a new area which may be difficult, and I think the duodenal ileostomy itself, once you've cut the duodenum, is rather easy, because the anastomosis is low down in the abdomen. It's easy access, and it's usually done hand-sewn. The other difficulty is in the full duodenal switch operation, not the loop one, is the ileostomy with the measurements and the adjustments of this anastomosis to avoid having internal hernias or mixing the loops. Again, is an important step in the procedure.
So which one would you say is the most difficult of all of them?
I would say the duodenal dissection, to get used to it, and this transection.
And it seems like our audience also agrees with you that the duodenal dissection is the most difficult, followed by the duodenal ileostomy. Now, let me pose this question to Laurent. Now, you're someone who's done DS for a long time, so SADI for you will be a walk in the park. So, to someone who's just starting, how do you take someone who is not familiar with, especially if someone doesn't do oncologic surgery, doesn't do total gastrectomies, they're not going to deal with the duodenum at all. They do mostly bariatric surgery. So how can you go through a process by which you can actually make this duodenal dissection easy? Can you take us through the steps in your head? What do you look for when you do duodenal dissection?
That's a key question to be safe. I don't think you have to negligate the technical aspect of the duodenal dissection. You are close to the pancreas, to the gastroduodenal artery, to the bile duct. So, and especially some patients with high BMI. So we do, as you said, I think the technically easier step is to do like you would do a total gastrectomy. You go past the pylorus down to the first duodenum. Make sure you have cleared the attachment at the top of the hepatic hilum. Create your window there and transect the duodenum. But again, I would advise people who would be interested to start this procedure to have to do it with someone who's done at least 50 of those. It's not technically easy, and the anastomosis also is slightly different. Typically do it hands-on, so that's also something people probably have to switch from their practice, which is usually a mechanical anastomosis. So a word of caution.
So do you also feel that the duodenal dissection is the most difficult part, Laurent?
Yeah, I agree. When you've done this, I think you are fine. The other anastomosis, especially for SADI, that's the benefit of the SADI. You take out the lower anastomosis. You have one less mesenteric window. The bowel is reaching easier the duodenum. So really, yes, the anastomosis and the dissection, sleeve gastrectomy, people are used to do it.
I heard hands-on anastomosis twice, but I'm comfortable with staplers.
Interesting.
Why do I mean, why not just do a linear anastomosis? Like, can you convince me why hands-on? I heard it twice so far.
Okay, I tried circular anastomosis. The small bowel is usually too small for the circular. I switched from at the duodenum from circular to hands-on because we had the stenosis. And in terms of leaks, in terms of I felt the safety of the anastomosis, but I know excellent surgeon with excellent results are doing a staple anastomosis. It's more from, in my point of view, the length sometime of the duodenal stump that can be sometime a bit short. And when you get used to it, you are really in a good position. I think it's easier compared to the Huawei anastomosis, the DS anastomosis hands-on.
So Antonio has a question, but before you comment, Antonio, I want everyone to tell me what % of their practice today, we heard from Wendy, is SADI or DS? So Antonio, you start first.
30%, 35%, just a primary or a revisional. We still do one-way gastric bypass and a sleeve. We don't do one anastomosis gastric bypass. It's the only technique we don't do routinely in our department. We do sleeve, approximately 45%, one-way gastric bypass 20-25, and SADI is 30%. Maybe it's our approach.
And you had a comment you wanted to make?
Yeah, a comment about the linear stapler anastomosis, as Lorraine mentioned. We already did the circular anastomosis. Do you remember Michel Gagné approach transoral, putting the device, and we had the same experience having a stenosis. We abandoned this procedure, but we start doing linear those time at the beginning of our experience. We perform almost 100 linear anastomosis with a 30 millimeters device. Putting 2 holes in the duodenum and another in the ileum, and implementing the device there. And one day after almost 75, 80, we perforate the ileum and the duodenum at the same time, in the same procedure. This day we did a manual anastomosis. Since then, we are doing manual anastomosis. But anyway, now we are performing a prospective study comparing linear and hands-on. We have included 20 patients in each arm, but no problem in any of the patients. I don't think going to be having any difference regarding that at the remand.
Right. So Miguel, can you tell me, in your opinion, which one is the most difficult step of the operation, and tell me what % of your practice is SADI or DS?
I agree with the rest of the people that the most challenging part of the operation is the dissection of the duodenum. And it can also be the anastomosis if you are not familiar with hands-on anastomosis, because I think the way to go is hands-on anastomosis. In my practice, SADI is about 5% or less. But I would like to explain why. Although in Mexico, obesity is highly prevalent, we see rarely patients with super obesity. And we select for the SADI procedure patients with either super obesity or patients who have failed to a sleeve gastrectomy. So from the total of patients who fail to a sleeve gastrectomy, we always offer two procedures: conversion to a Roux-en-Y gastric bypass, conversion to SADI. We explain the patient the pros and cons, and I would say that 30% of the patients select SADI and the other 70% select Roux-en-Y gastric bypass.
Right. So finally, the same question to Vivek.
Yeah, so in my practice, about 25% of it is DS or loop DS, 25% is gastric bypass, and 50% sleeve gastrectomy. And just one comment about the technical aspect of the duodenal dissection, because I think that you're hearing a common theme, which is that that's the most challenging technical part. I agree with Dr. Bierto in terms of with the pyloric mobilization to really free up that first portion of the duodenum, especially early in your experience. I think that that's a very helpful technique to become familiar with mobilization of that proximal duodenum. But the approach that we really champion and feel strongly about is really limiting the duodenal dissection to a tunnel that you create at the line of transection distal to the pylorus. In doing so, I think that there's less disruption of blood supply to that duodenal cuff, and in the long run, since blood supply is an important part of anastomotic integrity, once you become familiar with the anatomy, you can certainly do that type of dissection and I think reduce the risk of complications.
Thank you. So there's a question from Convoy Tai in the chat, and I'll pose it to Dr. Ali Abbas. How soon the nutritional deficiencies come up post-op and how they present? Is it through regular blood tests or clinical symptoms? And there was a comment made by Professor Prachand that you need to make sure that these patients have their nutritional deficiencies assessed before surgery. So Ala, please.
Yes, it's a very nice question. I think the beauty of the loop DS is that you have a measurement of the common channel, which is what we do regularly, the 3 meters, not just 2.5 as the operation started, which is a big difference from the standard duodenal switch where you do it the common channel of 1 meter. So having this length of common channel again makes this operation as a strong metabolic and revisional surgery operation are in a better situation than the redo Roux-en-Y gastric bypass with a long biliary limb or a single anastomosis gastric bypass with 2 meters excluded limb, because in these other two operations you have not measured the common channel. In this operation we measure the common channel and we select our patients, either they are coming for specifically metabolic surgery or they are revisional cases, and they have to respect the policy of having their supplements regularly and having their blood checks. We do the blood checks every 3 months for the first 2 years, and usually they present with the deficiencies after 6 months. And most of these patients who present with the deficiencies are the patients who declare themselves not being regular in getting their supplements. And by doing these tests and making sure of very good strict follow-up plan for this type of patients, we can usually catch up with these deficiencies early on and get the patient to continue. But for patients who are not responding to this nutritional advice and not being able to support the procedure with good replacement, we have revised this operation into a less aggressive, nutritionally aggressive operation. As regards the percentage of my work, it's about 15% of my cases are SADI-S mainly for revisional cases. Another 5% primary cases who are mainly metabolic patients.
Thank you, Professor Abbas. So I'm going to pose the next question to Dr. Birtu. There's a question from Andrea Forlan. Thanks for the presentation. In our experience, the major problem with SADI-S is the bowel movement alteration and worse smell of feces. Any comments about that?
I would agree to some extent. Compared to standard DS, I feel that SADI have less problem with increased flatus, bowel movement. I would really recommend looking at the diet first. Too much fat, of course, would create steatorrhea. Refined sugar will have bloating, abdominal pain, and so on. So have a nutritionist really experienced in the DS and SADI alimentation. Also, I would look, I don't know if it's a 250 or 300 centimeter common channel for the loop DS. And if it doesn't work, we are quite aggressive on the probiotics, Questran, sometimes bile acid fixation. We also give sometimes a course of flagyl like metronidazole to decrease bacterial overgrowth. So in the vast majority of patients, the weight loss really are so good that the side effects are usually considered as benign, but they are not. They need some specific treatment and some specific experience to manage those well.
Thank you, Laurent. So next question is going to go to Professor Perton. There's a question from Andrea Lazaro. What is your position on right gastric artery ligation when you're dissecting the duodenal dissection? And if someone else has a different opinion than him, please chime in.
Yeah, thanks for the question. So the division of the right gastric artery for mobilization of the duodenum to try to reduce the tension on the anastomosis was described and published by Marcassini's group from Brazil. And in their approach, they did it routinely and did not have any complications associated with it. So it certainly can be done. But having said that, in my experience, having been doing DS since 2002, I have never had to mobilize or divide the right gastric in order to get adequate duodenal cuff mobilization to do the duodenal ileostomy. So again, my default is when preparing bowel for doing an anastomosis, the better the blood supply, the better your outcomes are going to be. And so I think that if you can avoid disrupting blood flow to an anastomosis, you're going to be better off.
I have a comment on that, Abderrahman, regarding this issue.
Yeah.
I think, another point, supporting, Vivek, Dr. Pranchad statement is when you avoid dividing the right gastric artery, you at the same time are preserving the vagal innervation of the lesser curvature of the duodenum. But also has to be important in decreasing the dumping and the physiology of this area. You're not only increasing the blood supply, you are also preserving the vagal and the neurocrine and paracrine effects of the procedure.
Okay, excellent, thank you. Before we launch the next poll, there's a question from Rock Bauman, my partner here in Charlotte, posed it to Miguel. What's the incidence of reflux, bile acid reflux, and what patient qualifications are there for someone who has preoperative reflux? Meaning, someone has reflux, would you offer them SADI while they have reflux?
Well, we try to avoid SADI when patient has reflux because we feel that reflux may get worse. The incidence of new reflux after SADI, I think, is very low. And we haven't faced a major problem with bile reflux after a SADI procedure.
And what do you use to actually check for reflux? Do you do pH studies? Do you just do an endoscopy? Do you do a questionnaire?
Well, first of all, we do the clinical interview. If the patient has symptoms of reflux, we do the full testing, but we basically do the workup based on the clinical findings that we get when we see the patient.
Okay, so let's have Manuela launch the next poll for us. So let me pose this question to Wendy, even though she said she doesn't do SADI, but I'm hoping that after your review, you're considering your position. So what do you think is the ideal patient for SADI, Wendy, in your opinion?
I think I would be looking at SADI in someone where either they've failed a more restrictive procedure and we're looking for some more malabsorption, or where the degree of weight loss that's required to get the metabolic effect that we're looking for. Because I think we always have to remember we're doing health-giving surgery rather than weight loss surgery. So we should be looking to see, how much weight do people really need to lose to get that health benefit. So I guess I'd really like them to have I guess the super morbid group, they definitely need to understand the procedure, because we really need buy-in so that they do take those vitamins. As I said, I inherited a practice when I was a relatively young surgeon of people that had had either DSs or Scopinari procedures. And when I followed patients up, I found people with, night blindness, Korsakoff syndrome, really quite horrifying malnutrition. So people really need to understand the procedure and understand the need for their nutritional supplements. And I think if someone's really got severe metabolic disease, you could make an argument from my reading of the literature that these kind of procedures that do have quite a strong neurohormonal effect may be potentially a little bit more effective, although, having said that, we don't have the evidence to support that statement. That's just conjecture. So I guess if I had those ones, I'd say all of the above.
So thank you, Wendy. So the audience is kind of quite split, but most everybody feels all of them, and the single one that's the most ahead is super morbid obese. So people feel all these are factors. Let me pose a question to Dr. Birtu. So if you have a patient who's morbidly super obese, the BMI 70, 60, but you're concerned about their understanding of the SADI, you're concerned about, you're just not feeling they're the ideal candidate. How do you approach such a patient?
Well, I think that's the beauty of the sleeve as a step approach to DS. You don't cut bridges, so you go with the sleeve, see how the patient responds to compliance with vitamin, with follow-up, with blood works. That gives him time to adapt to the surgery. And then that gives you that window to make sure that the patient doesn't disappear. That can be a catastrophe if you do a DS in a patient that is not compliant. But even after 30 years of experience with DS, we still get those cases that we think that's perfect patient, and then the patient disappear, and we have to chase him to make sure that he do his blood work. So I think a step approach is a good choice.
So Vivek, in Canada, it might be easy to do a step approach. Can you do that in Chicago?
What we'll do in terms of step approaches, with regards to insurance, oftentimes we'll actually get approval for the entire operation. But using safety considerations, for the super obese and so forth, with the potential for massive hepatomegaly or severe visceral adiposity, just from a safety perspective, it's actually better to stop after the sleeve, because after all, that's where sleeve gastrectomy came from, was due to physiologic compromise in a patient undergoing a laparoscopic duodenal switch back in 2000.
Thank you. So the next question goes to Dr. Ala Abbas from Michael Reisers. What about the risk of pyloric disruption if you use a linear stapler with duodenal ileostomy? Do you feel that's an issue at all?
It's a very nice technical question. To get a good cuff of duodenum, I think an important landmark is to go just flush with the gastroduodenal artery, creating the tunnel behind the duodenum rather than going from the above. With this technique, you preserve the good blood supply to the duodenum, and you have a good 3 to 4 centimeters of duodenal stump length, so you can do the anastomosis. And doing the anastomosis manually saves this problem of handling the duodenum, which is very fragile, and the ileum, which is very tight, with staplers. So when we started off, we used linear stapler, and it was a hassle, and we ended up usually with big windows to suture, almost equal to the hand-sewn anastomosis. So the hand-sewn anastomosis, this type of anastomosis, duodenal anastomosis, lends itself to manual suturing much easier, especially the location of the situation. But I have never had a problem with this linear stapler at the beginning to disrupt the pylorus, because we have a good cuff of duodenum. But as Dr. Torres mentioned, it is very easy for the stapler to perforate the duodenum from the other side, or the ileum from the other side. So I think if someone is contemplating to do this procedure, is to make sure that he can do a comfortable hand-sewn anastomosis.
Thank you very much. Next question goes to Antonio. So there's a question from Gilberto Ansan. If you have a patient with a sleeve gastrectomy, but they also have reflux, do you do DS? Do you do SADI? Do you do something else?
Okay, I think, the first thing we do in a routinary way is to study very, nicely the GER. I mean, we perform manometry, we perform a pH-metry, of course, endoscopy. If the patient has a severe GER, I mean, Barrett's esophagus, the Mister score over 80, pH below 4 of 30%, I mean, a severe GER, we don't offer them a DS or a SADI procedure. We offer them probably, if you're going to be losing weight or some metabolic control, Roux-en-Y gastric bypass with a longer biliopancreatic limb, going to be ideal in those patients with severe GER, with Barrett and so on. But it's as a second step procedure, depending on the aim of this second procedure. I mean, it's going to be due to weight regain, not losing weight, or not metabolic control of the comorbidities. It depending on the aim of this second step, your approach with the different patient. If the question is that the sleep previously failed, probably, you go to think about performing SADIs, studying the GER properly. But if the patient, in other words, the patient doesn't have a very severe GER, I mean, doesn't have a grade C esophagitis, doesn't have a very high Tom de Mister score, a very high percentage of pH below 4, it's not a severe GER, no Barrett, we have to specify what is going to be our aim. And it's not a very severe GER, we can go forward doing a SADI procedure. But
Vivek,
the patient has severe GER with the wrong way with longer BPD then.
Thank you. Sorry to interrupt. Vivek?
Yeah, I just wanted to make a comment. Obviously, GERD is really important, but I do think that it needs to be interpreted in the context of everything else going on with the patient. So if after sleeve they have severe GERD, but their BMI is still 57, and they still have very severe diabetes, I actually think that it would be reasonable to do a duodenal switch, not a loop duodenal switch, because remember, with the duodenal switch, you are diverting bile. And bile is an important pathophysiologic mechanism for the problems with reflux. So I don't think that a standard DS is going to completely disappear, and that would be, I think, a very important utilization of that approach.
I agree with you, Vivek, completely. Your aim is to control the metabolic profile of the patient, and to get more weight loss. For sure, the standard Roux-en-Y DS, in my humble opinion, going to be the only place, Vivek, in my opinion.
So we're gonna launch the next poll, and then I would like the faculty to do a rapid fire, quick questions, because we still have questions, and answer them. So next one goes to Laurent Bertu. What are the most common frequent vitamin deficiencies after SADI? Thiamine, ADEK, B12, folic, B6, or vitamin C? Laurent.
So I would go with EDEC. Typically, they are quite frequent pre-operatively in Quebec. To give you an idea, 60% of the patients before surgery have a vitamin D deficiency. It's about 30%. We don't typically measure it. We supplement it directly. We give them a multivitamin before surgery, including ADEX and thiamine. Of course, thiamine is typically can be much more severe in terms of encephalopathy and convulsion and neurological problem, and more acute. So I would go with ADEC.
And do you supplement preoperatively EDEC separately, or is the same regular multivitamin?
No, we have a multivitamin, high dose multivitamin complex, and we give them we give all patients a routine vitamin D supplementation. We give them 10,000 D3 units of vitamin D for 1 month, and then we give them 1,000 vitamin D up to the surgery. And after surgery, they get 20,000 of vitamin D3, 30,000 of vitamin A, and those two multivitamin complex for the E and K. So that's high dose, and that's not the typical dose for a Huawei or a sleeve. Much higher.
Well, I am quite impressed. Seems like they're spot on. Miguel, question from Gilberto Ungson to you. He says in Mexico it is difficult to get ADEC. What do you do for your patients?
Well, that's true that we don't get multivitamins with enough amount of each of that vitamin, so we supplement them individually.
Individually, okay, very good. So the next question is going to go to Ala from Gaylor Acosta. What if SADI fails on weight regain? What's next?
Yes, it's a tough question. But again, if you have a revisional surgery, you have to study it properly. You have to study the reasons for the weight regain. Recidivism, as you all know, may well be in patients' eating behavior that can be corrected without any further intervention. Then if you go next to study your work, you have to study the size of the sleeve left, because some people who leave it really huge sleeve, to make sure that these patients will not get into protein energy malnutrition. And the problem with these patients would be the size of the sleeve that needs to be resized. The last point again would be the measurement you have done. A failed measurement, if you have done a capacious long limb common channel, then it compromises the procedure. If you're leaving 4 meters, 5 meters, not 3, then you have to shorten your common limb. But probably if you are going to go technically for a further bigger procedure, the choice would be a full duodenal switch.
Sure.
Thank you. So distalization of the procedure, as well as being a Roux-en-Y configuration.
So I want to remind the faculty of the rapid fire. We just have 7 minutes more. So Vivek, I don't want to put you on the spot, but someone is asking from the Netherlands, Ian Finite, do you have a video online that people can see your technique?
I don't have one online. If you had been at IFSO, that the meeting that Antonio organized, I did a live case from Madrid, so had an opportunity to show the technique. But I'm happy to share. If you send me an email, and maybe this will be the impetus for me to put something up on YouTube or something.
So if you share something with Manuela, we'll put it on the IFSO YouTube channel and put in a plug for the channel. So rapid fire, all the faculty who do DS, tell us your bougie size. Just we'll start. Miguel.
60.
Antonio.
64. 54. 54.
Vivek.
56.
56. Laurent.
It's 34, but it's used as a guide. It's not tied around the 34.
And finally, Ala.
56.
56. Also, rapid fire, a quick question from Joanna Morante. What are the ideal SADI measurements for a patient with a BMI of 47 and insulin-dependent diabetes? Miguel?
Well, I normally do 3 meters from the ileocecal valve.
3 meters. Antonio?
47 BMI?
And diabetes with insulin?
300.
300. Vivek?
300.
Laurent?
250.
And Ala?
3 meters.
Okay,
Okay.
there's a question from Professor Hempins. I'm glad you're tuning in, Jack. Question specifically to Laurent. What would you perform SADI? Would you perform SADI only as a 2-stage procedure? I'm not sure. Go ahead.
I guess he asking as a second stage, we do it randomized. We still recruit patients for RCT. I like SADI as a single stage a lot. We finish recruiting for our RCT and have to publish the data soon. As a second stage, I'm still questioning Dr. Torres. Sorry, I trust you a lot, but I'm still questioning the long term of and as a second stage in patients who have a specific physiology. So we do it RCT.
Okay, great. This is a comment from Andrea Forlan. The major advantage of SADI that it has a pylorus and BPD doesn't. Most everybody agrees. Question by Ismail Al-Hamoud. This is going to go to Vivek. Is the results of primary SADI same as staged or redo SADI? Rapid fire.
The data that we have so far seems to be that is true, that you don't compromise the long-term outcome by doing it staged as opposed to single operation.
Thank you, Vivek. Next question goes to Miguel from Gonzalo Gutierrez. What might be the best option with duodenal anastomosis leak that needs reoperation? You redo the anastomosis or do you transform to the duodenal switch? Obviously, there is now biliary peritonitis and it's a mess.
Well, I think that depends what's the situation. If you can redo the anastomosis, I will go first trying to redo the anastomosis. If that's impossible, I would try to convert the procedure to a Roux-en-Y.
Anyone else has comments on this difficult case? Leak after SADI with biliary peritonitis, Vivek?
Yeah, I think the comment that I would make is that I think that is one thing that's qualitatively different when you compare standard duodenal switch to loop duodenal switch, is that the presence of biliopancreatic secretions at the duodenal ileostomy, the implications physiologically and from a sepsis perspective are going to be different with loop DS versus standard DS.
So I'm going to have, before we answer the last questions, and I want to thank the faculty for answering the questions very, very quickly. Can we launch the final poll, Manuela, for our audience? And I'm quite impressed with the answers of our audience. It's always matching the faculty. So a final question is about hypoalbuminemia in a patient after SADI DS. I guess this question clearly goes to Wendy because Wendy has dealt with so many of these patients when she was just starting her practice. So Wendy, what do you do? What did you do when you were inheriting all those patients?
So do a thorough workup and try to measure the lengths as best you can radiologically. And in fact, we're finding MRI enterography quite helpful if you want to check the lengths and see that there's not been a mistake made. But you know, there's a lot of reasons that can cause the hypoalbuminemia, but often we found the limb lengths were incorrect or too short. So these were not SADIs, they were either BPDs or DSs, and we found that the common limb was kind of short, so we basically lengthened the common limbs for most of them after getting adequate nutrition, so usually need a period of TPN.
Sorry to interrupt. Can you comment more about this MRI enterography? Is this a special technique? Is this something that we can do at our hospitals?
Yeah, so we only started doing it the last couple of years when we've had sort of complex patients that have lost too much weight or are having trouble maintaining nutrition. And predominantly in our practice, that's Roux-en-Y or one anastomosis bypass. And you can get an MR entogram of the bowel, and with the coronal views, you can actually measure out quite nicely, we think, the limb lengths. So it's kind of reassuring that you haven't done the wrong thing and plugged the wrong, haven't, done a Roux-en-Y or haven't inadvertently sort of measured very short limbs. And, so it's kind of early days in looking at this, but it's kind of neat.
Very nice. I think this is a very good piece of advice, and I think the group tuning in agrees with you, Wendy, that the common channel is probably the main reason. There's a question from Jack Hempins about any consensus on the length of the common limb. And for the sake of time, Jack, I think everybody does 300 with the exception of Laurent, who does 250. Is that correct?
No. In this patient, if the patient is a lower BMI, if the patient is a higher BMI, I agree with Laurent. The patient you told me 40, 48. And if the patient is more than 50, I think the ideal, I agree with Laurent, is 250. But if the patient with a lower BMI, you have to increase a little bit the common channel. I don't know, this 50 centimeter is going to be the final solution, but our standard length of the common channel is 250.
Okay, Vivek, do you do for super obese 250 or 300? 250. 250, okay.
For super obese meaning like 55, 60 and higher.
There's a question from Rock Bauman, my partner in Charlotte again. What surgical alternatives are suggested for the SADI patient with malnutrition? Let's pose that to Ala Abbas from Egypt.
Yes, we had to revert some of these patients. Obviously, you have to lengthen the common channel. You cannot regain this resected sleeve, and if the limb is too short, you have just to move it up 1 meter.
If it's a SADI, how do you lengthen the common channel without disrupting the duodenal ileostomy?
No, you revise the duodenal ileostomy.
Is that easy to do?
Yeah, it's possible.
Possible. So I can see Antonio smiling and Laurent smiling. That means it's not easy.
I don't agree. I think it's very easy.
Okay, all right.
The patient already lost weight. You can divide, you put the stapler in the ileum phase of the anastomosis, and you can preserve the ileum, and you have a cap for performing another anastomosis, as Ala said.
And you attach at how many millimeters from the ileocecal valve?
Excuse me?
So you lengthen it by how much?
1 meter, 1.5 meters, depends. We have faced with some patients, in those cases, you have to measure the total bowel length. We faced with a couple of patients with only 5.5 meters. 5.5 meters. So in those patients, we enlarge 1.5 meters, so increasing the length. You have to measure all the bowel and to be sure of having at least 3 meters, 3.5 meters a common channel.
Okay, so final two questions. Michael Reister's question to Laurent. Is revision of sleeve to SADI or DS an ideal indication for robotic approach? Certainly when hand-sewn duodenal ileostomy is favorable.
Acceptable for what, sorry?
Robotic approach.
I don't do robotic. If you have a robot, enjoy it. Yes, definitely. You have less movement in the abdominal cavity, so you have, and especially for the suturing. I tried it a few times, especially as a fellow. I liked it a lot, but we don't have the money to in Quebec. We don't have the money for a robotic DS. So yes, it's a nice case, especially for hand-sewn.
So I'm going to ask two final questions, and both final questions to the entire panel, but rapid fire. First one came from Vivek. Where do you decide where to divide the duodenum? So let's start, Miguel.
Well, I will try to go 2 centimeters from the pylorus.
Antonio?
As far as I can, close to the pancreas. Our limit in the gastrointestinal artery, go far away to get as much duodenal cuff as we can.
Vivek?
Yeah, so if you retract the first part of the duodenum anteriorly, you get a sense of where the head of the pancreas is fused to the duodenum. So that's the limit that I try to aim at.
Okay. And Laurent?
Inferior approach, I stop when I see the gastroduodenal artery. And posterior approach, as Vivek, I see the little bulge of the pancreas just before that.
Okay, and Ala?
Yes, if the posterior dissection flush with the gastroduodenal artery, this is the landmark. Below that, the pancreas is stuck. So it usually gives you 3 to 4 centimeters stump.
Okay, thank you. Another rapid fire question. In terms of gallstones and removing the gallbladder, what's your approach, Miguel?
We do not remove the gallbladder routinely. We give the patient source of desoxycholic acid after surgery.
Antonio?
If the patient is very, very symptomatic before SADIs, we perform cholecystectomy during the same procedure, but we start performing cholecystectomy because we have a couple of cases you only can do cholecystectomy because it was so challenging.
Perfect. Very good advice, Vivek.
Same approach as Miguel. Unless they're symptomatic, then we'll do it at the same time.
Ron?
I feel like the black sheep again, but we do routinely cholecystectomy. We did not, but we had like 30% of the patient who came back with gallstones, and it can be, it's not as a gastric bypass, but you can do ERCP. It's not as easy if you have a cholecystectomy. So routine cholecystectomy takes 15 minutes typically.
And initially, did you give patients ursodeoxycholic acid?
Yes, we do, yeah. When we have to leave the gallbladder, when the liver is too fat or too difficult, we give them ursodeoxycholic for 6 months.
Ala?
Only if they have the gallstones. Even if it's asymptomatic gallstones, we remove the gallbladder. But healthy, normal bladder.
Okay.
Healthy,
Right.
we leave.
So the final question, the final question to the entire group comes from Juana Morante. It's the perfect question. Do you think that sleeve revision surgery with the expansion of sleeve without reflux is changing, and that SADI is the best option for this procedure? Miguel?
Well, I think that's a very good alternative when the sleeve failed to do the SADI, because you only have to do half of the operation, and then you will get an important weight loss.
Antonio?
For sure, I think so.
Vivek?
Yes, to me, revising a sleeve to a bypass for additional weight loss doesn't make a lot of sense because the weight loss difference between those two operations independently is very modest at best. It's great for reflux, but not for additional weight loss.
Laurent?
Agree with Vivek and Antonio and everyone. Good option. You don't have any scar tissues there.
Wendy?
I guess I disagree because I still think the bypass can offer different weight loss to a sleeve. I think the mechanisms of action are quite different. And so I think there is an opportunity, and I think I would like to see some RCTs to inform my practice, because at the moment I don't think that we have enough evidence to say that SADI is better than Roux-en-Y.
And Wendy, do you do something different for your Roux-en-Y when it's a revision after sleep? Or it's the same Roux-en-Y?
Same Roux-en-Y.
Why?
Maybe the pouch might look a little longer these days. I think we're tending to make our pouches a bit longer.
Ala?
I think especially for metabolic patients and super obese, going to the SADIs is quite logic.
Okay. Well, first of all, I want to thank Wendy and Miguel for their work on this position statement. It's really has been tremendous. I want to thank Manuela for all the work in the background, all our attendees for the excellent questions, and for the faculty. I mean, this has been a tremendous hour. I learned a great deal. Thank you so much, and look to the recording in the IFSO YouTube channel and the IFSO Virtual Academy. And I wish you all a great day, or good night to Wendy.
Thank you. It's good morning here now.
Thank you. Thank you, everybody.
Thank you very much.
Guys,
Really.